So, Dr. Allen.
Good evening. Welcome to the Gateway Medical Society's webinar. We're very pleased to have you join us this evening to discuss issues that relate to African American men and their health. In 1963, Gateway Medical Society was formed as a component society of the National Medical Association. And in that way, we are inextricably linked to the National Medical Association as their values reflect our values. Our mission is to close the gap in racial disparities among people of color in our community. We're very pleased to have you join us this evening. And we are very happy to have, as our moderator this evening, Dr. Chentis Pettigrew, Jr. Dr. Pettigrew is currently the Associate Dean of Diversity, Equity, and Inclusion, Assistant Dean for Student Affairs, and Assistant Dean for Faculty Diversity at the University of Pittsburgh School of Medicine. Dr. Pettigrew has held many administrative and teaching positions throughout this country, including both here in Pittsburgh, in UCLA, at Tuskegee University and Florida State University. He's recognized nationally as someone who has really paid his dues and has been a promoter of diversity in our medical schools. He received his BA degree in political science at Westminster College. He received his master's degree at the University of Pittsburgh, and his doctorate was obtained at the University of Pepperdine. Please welcome Dr. Pettigrew to our conversation.
Thank you, Dr. Allen, for that introduction. And again, to all of you, welcome to the Brother to Brother virtual community symposium brought to you by the Gateway Medical Society and the Pittsburgh chapter of the Links Incorporated. You've heard about Gateway, so let me tell you a little bit about the Links very quickly. The Links Incorporated is an international nonprofit corporation with 292 chapters. It is one of the nation's oldest and largest volunteer service organizations of extraordinary women who are committed to enriching, sustaining, and ensuring the culture and economic survival of African Americans and other persons of African ancestry. The Pittsburgh chapter of the Links Incorporated was chartered in 1948 and has more than 7 decades of service and friendship in the Pittsburgh community. The chapter is committed to implementing transformational programming to enhance and elevate those that they serve. The Pittsburgh chapter works in alignment with Links Incorporated and its 5 facets: the arts, services to youth, national trends and services, health and human services, and the international trends and services. The Health and Human Services facet is facilitating this webinar in conjunction with the Gateway Medical Society. We also have the pleasure of having some esteemed physicians with us this evening. We have Dr. Paul Dafe Ogagan. He is an assistant professor of urology at the University of Pittsburgh School of Medicine. He graduated from the University of Pittsburgh School of Medicine. He did his residency in general surgery at the University of Pittsburgh and his training in fellowship in urology at the University of Pittsburgh as well. He has a number of clinical specialties that will impact this conversation tonight, in particular, prostate cancer and kidney cancer. Dr. Stephen Evans is with us this evening as well. Dr. Evans is a clinical professor of surgery and surgical oncologist whose primary practice is at UPMC Shadyside. He also serves as the Director of Community Engagement for the Department of Surgery and has dedicated a large part of his career to closing the divide and disparities in healthcare for minority populations in the Pittsburgh region. Dr. Evans is the recipient of the 2019-2020 Leon Crape MD Excellence in Patient Care Award. The award is an annual honor given to UPMC Health Cancer Center physicians who have demonstrated work-related efforts that are truly above and beyond the course of normal duty clearly contribute to the overall quality of success of UPMC Hillman Cancer Center. Also, Dr. Evans was selected as a winner of UPMC's Award for Commitment and Excellence in Service in 2020. He is the Director of Community Engagement for the Department of Surgery. Dr. Evans serves as the physician leader engaging our faculty, medical students, and our residents as volunteers to administer COVID-19 vaccines to the most vulnerable populations disproportionately impacted by the pandemic, one shot at a time. We also have Dr. Chris Allen, MD. Dr. Allen is an associate professor of medicine at the West Virginia School of Medicine and an interventional structural cardiologist at WVU and the Vascular Institute. He is chair of cardiology at WVU Wheeling Hospital and at WVU Reynolds Hospital. He received his training in internal medicine at Howard University, where he served as chief medical resident. He was elected to the prestigious Medicine Honor Society Alpha Omega Alpha in his senior year. He was then accepted into the cardiology fellowship training program at Howard University Hospital. He completed this training in interventional cardiology at the University of Massachusetts Medical Center. He moved to Pittsburgh in 1995 and joined the practice of Donahue Cardiology. He joined the staff at Allegheny General Hospital, and his love for teaching and mentorship was recognized when in 2001, he was awarded the Distinguished Interventional Cardiology Teaching Award by the staff and fellows at the Department of Cardiology. He then moved to UPMC Heart and Vascular Institute and was a clinical associate professor of medicine at the University of Pittsburgh School of Medicine. He was the medical director of the cardiac catheterization laboratories at UPMC Shadyside Hospital and director of peripheral vascular intervention in the Department of Cardiology, UPMC Shadyside Hospital. He was also program coordinator of the Cardiology Fellowship Training Program at UPMC Shadyside. So that we have a august group of physicians with us this evening. Our task tonight in our Brothers to Brothers conversation is to really consider and deal with the issues related to the care, the health of African-American men in this community. You should know that there are a lot of challenges that exist. 44% of us are obese. We also live 7 years less than our white counterparts. The causes of death from 1 to 5 include heart disease, cancer, unintended injuries, and homicide. Dr. Stephen Evans is going to talk to us about preventive healthcare as it relates to making sure that we as men are available to our families as long as we can be and be as viable and healthy as we can be in that time. Dr. Evans.
Thank you, Dr. Pettigrew. And I just want to thank Gateway Medical Society and the Links and Brothers to Brothers and Gateway Health for just providing this platform for us to come together and have this very important conversation. And I'll just start out with this serious note. As you all know, the number of persons that have succumbed to COVID-19 to date has been over 690,000. And just as Dr. Pettigrew had said, the leading cause of death in the United States have been cardiac disease, and cancer is number 2. But the pandemic has magnified existing disparities in healthcare access and cancer outcomes. And so with cancer being the second leading cause of death, let's break out and address this question tonight. Does race matter? That's the question I pose. We often hear that Blacks are often succumb and have worse outcomes according to all cancers. But what is race? Race is a social construct. It's been used historically to codify practice that generate and perpetuate inequities among racial and ethnic groups that I feel contribute most to the disparate health outcomes. What I challenge you to consider tonight or during this program is to look elsewhere and to entertain the idea that cancer disparities and outcomes are a result of social determinants, such as zip code, where a person lives, poverty, financial insecurity, employment status, insurance status. The pandemic has limited access to preventive care, screening, and early detection. I feel that these factors contribute more than race to the disparities that we see in cancer outcomes. So I would postulate that we need to get back to screening and early detection, because that's what matters. With screening and early detection, we can identify cancers at the early stage and promote long-term survival as a result. That's the goal of screening, to identify cancers when they're early, to lower the death rates, and to identify people at higher risk due to genetic mutations. In March of 2020, you know and you saw that screening and preventive health came to a screeching halt. Lockdown and stay-at-home orders allowed only essential workers outdoors, and face masks became the new norm, and social distancing was mandated for everyone's safety. And no one knew whether it was safe to come in to get screenings, such as, for example, that we know are most important for lung cancer, low-dose CT scans of the chest. Millions of people are qualified to get such an examination that can identify 80% of lung cancers early, but less than 13% of persons who have a long-standing smoking history of greater than 20 years, age 50 to 80, and or have stopped smoking in the last 15 years, or who are current smokers, even take advantage of that screening tool. For colorectal cancer, the death of Chadwick Boseman, Prince King T'Challa, Black Panther, has elevated the awareness of colon cancer in our Black men. Chadwick Boseman was only 43 years of age. So this is a very important subject for us to have. And we know, unfortunately, the highest incidence of colorectal cancer in African Americans, unfortunately, are in the younger age groups before the recommended age of screening, which in May of this year was reduced to 45. So just the other day, I had a patient who is 30 years old with colon cancer, and a young 30-year-old man who I met 30 years ago was diagnosed with colon cancer, and due to a whole host of circumstances, being self-employed, losses insurance, and fortunately, after having his colon removed 10 years later, he is still alive. But that didn't have to be how his story ends as successfully as it does, because he lacked access for health insurance, and for many a long period of time, that was not able to make his appointments and undergo chemotherapies that was recommended. So also I want you to consider breast cancer in men. Men also get breast cancer, though it's only 1% of those men, but African-American men can get breast cancer. And generally, if that population has breast cancer, they may also have a genetic mutation, such as BRCA1 and 2, that can not only lead them at increased risk of other cancers, such as prostate cancer and pancreatic cancer. So here again is another evidence that genetics, socioeconomic status, health insurance status, and poverty can be great influences in cancer outcomes. So that's the conversation I want us to engage in tonight, so that we can be more aggressive in doing screenings for colorectal cancer, when our doctors recommend even a DNA study test of our stools or colonoscopy. These studies can be performed safely, along with the CT scans of our lungs and mammograms for men, to identify cancers at their early age, so that we can continue to live and thrive and be the kings as we were represented in Wakanda.
Thank you very much, Dr. Evans, for those opening remarks. I want to remind everybody as we go, I am monitoring the chat, so if questions come up in terms of any of the things that you're hearing or any of the things that may be on your mind, this is a really fantastic opportunity for you to hear from experts that are here, right here in our region. At this time, we're going to hear from Dr. Chris Allen. He's going to make some remarks as well. And I will be, again, monitoring the chat, so that if there are things that you want to know about, please put them in the chat, and we'll address them as we go. If we don't get any questions during the presentations, we'll certainly have another opportunity at the end of the presentations for questions. So thank you. Put it in the chat if you can, Dr. Allen.
Thank you, Dr. Pettigrew. I would like to lend my voice to that of Dr. Evans, who started out the conversation about risk factors and the effect that COVID-19 has had on the minority populations around the country. Part of the whole presentation of the disease process, as we know, is that African-American men are very high risk for having significant cardiovascular disease. The second point is that they do not present early to the hospital or to their physicians due to many reasons. Some of it may be lack of trust. Some of it may be not understanding the presentation. Some of it not being hesitant just to come to the hospital to seek care. And that also has many facets and is related to their social standing, which is related to the possibility that they don't have any insurance, and therefore they turn up late in presentations and therefore have greater morbidity and mortality. Now, in closing this gap in presentation, what we like to do is make sure that they understand the disease process, one. Number two, recognize when it is present. And number three, seek help. Cardiovascular disease, as was mentioned by Dr. Pettigrew, is the leading cause of death around the country. And even in this COVID-19 pandemic, it remains the leading cause of death. The problems that we now see, as Dr. Evans alluded to, is that our patients present much later along. And as you know, having a heart attack or a stroke, time is very important and will be determinant for their long-term outcome. We now see patients presenting more than 12 hours after initiation of symptoms, where revascularization can happen. However, their long-term outcome is significantly impaired. So our job is to go into our community and to raise their awareness and say, despite what has been happening as far as this pandemic is concerned, if you're having symptoms suggestive of cardiovascular disease or stroke, you should seek care early. The earlier, the better. The later, there is more morbidity and they have very poor outcomes.
Thank you very much for enlightening us, Dr. Allen, as it relates to cardiovascular disease. One of the things that becomes important as in my life is also knowing the family history. And the family history is also helpful in making sure that you make the preventative decisions that are appropriate, important, and in time. I needed the services of a cardiologist, and you never really want to need the services of a cardiologist, in real time. But I am still here because I was fortunate. Had I really taken into account my family history, I might have taken some different steps early enough not to have needed interventional cardiology care. But thank you, Dr. Allen. That is certainly enlightening and very important conversation. We now will hear from our urologist. He can tell you what that really means. Dr. Paul Dafe Ogagan is here to make a brief presentation as well.
Thank you, Dr. Pettigrew, and thank you to Gateway for inviting me to this panel. I just wanted to start off by talking briefly about urology as a specialty in general. Most people don't really know what urologists do. We deal with the genital urinary tract system, starting with the adrenal gland, the kidneys, the ureters that drain the kidneys, the bladder, prostate, and the genitals. We deal with diseases of all those organs. Today, I really want to focus mostly on prostate cancer because prostate cancer is one of the diseases or cancers that predominantly African Americans or Black males have a higher incidence of the disease as well as mortality. And there's a number of reasons why that is. And my colleagues on this panel have alluded to some of those reasons. Genetics is one reason. Dr. Pettigrew mentioned family history, and that is a pretty big, important factor for patients with prostate cancer. Patients who have a first-degree relative of prostate cancer, meaning a father or brother with prostate cancer, have an increased risk of at least 2 to 5-fold risk of developing prostate cancer. So that is a pretty, good reason to know what your family history is. And in African Americans, the mortality, as I mentioned earlier, for prostate cancer is about 4 times higher than the Caucasian population. And this is a real reason why, men should really be seeing urologists. And as a matter of fact, men, Black men, typically don't like to see urologists for whatever reason. And one of the reasons being that the digital rectal exam, for instance, because that's one of the reasons why, that's one of the ways we can, diagnose prostate cancer, by digital rectal exam. And masculinity is one factor that, men avoid, digital rectal exam. But unfortunately, that is one of the most important ways we can diagnose prostate cancer, in addition with PSA. So men who are at the age of between 50 and 69 years old are highly advised to visit the urologist at least, once or twice within the 3-year span, if not on a regular basis. Now, if you have a family history, that age group goes down to about 45. So men who are 45 years old with a family history of first-degree relative or father or brother should start getting their PSA checked around 45 years old.
Thank you, Dr. Ogagan, for that information. We do have some questions in the chat. One of those questions is directed to Dr. Evans. It says, Dr. Evans, my 29-year-old nephew diagnosed with colon cancer to his liver less than 1 month ago. He also changed jobs 1 week before the diagnosis. It has metastasized. Now insurance is an issue. He was scheduled for surgery on October 12th. Do you think his siblings should as well have genetic testing? How about early screenings for colon cancer?
Well, thank you for that question. Genetic mutations are important to become aware of with regard to colon cancer. After the tumor and the cancer is removed, the cancer cells will be analyzed for genetic mutations, and that can direct how the family proceeds with that information once that information is known. As I said, most colon cancers, even at the young age of 29, occur as random mutations in nature. And again, you see that people's lived experiences really can have a great impact also on access, his continued access to chemotherapy treatments, and can be impacted by his gap of having insurance. So it's really important to look at all of these factors when it comes to outcomes and long-term survival. I wish you and your nephew and the family well along this journey, and so that you all can continue to stay close by him and be a great support to him, because that would be greatly needed, because of family support can also be a factor into better outcomes and is greatly needed at this time. Thank you for that question.
Are there other questions that you want to put in the chat? This is a fantastic opportunity.
Dr. Daffy, I want to Ogagan, I want to pose that question. I'm talking about screening and early detection and prevention. As you know, formally, the United States Prevention Task Force had recommended PSA as a screening tool. And unfortunately, coming away from that recommendation has confused many of our brothers in our community as to what is the right thing to do. We talk about having family history. And so that conversation comes up over and over again. And I, being a 62-year-old African-American male, have that conversation with my physician as to obtaining a PSA study. What is its significance at my age? Can you walk us through that?
Thank you for that question and comment, Dr. Evans. Yes, the U.S. Preventative Service Task Force gave PSA a recommendation of D, basically saying that primary care physicians should not be ordering PSAs. That recommendation was given a few years ago, and that really made things confusing, not only to patients, but to physicians alike. Primary care physicians really stopped checking PSAs. And as a result, what we've seen now is that many patients who are presenting with prostate cancer are presenting at the later stages, with more aggressive prostate cancer, locally advanced prostate cancer, and sometimes metastatic prostate cancer. We as urologists do not agree with that recommendation from the U.S. Preventative Service Task Force. We still recommend that patients, specifically within the ages of 50 to 69 years old, because that is the age group where prostate cancer is most prevalent, should have the discussion with their primary care physicians about obtaining PSA. Like I mentioned earlier, if you have a family history of prostate cancer, especially if you are African American, we recommend that you should start that discussion with your primary care doctor at the age of 45. Now, it doesn't necessarily mean that we should be obtaining PSAs on an annual basis. And urologists have, and myself included, have started checking PSAs less frequently than on an annual basis. Typically, if prior PSAs have been stable, I will wait 2-3 years before checking another PSAs. But we still recommend that patients should still see their primary care physicians and urologists for digital rectal exam, because sometimes PSA may not tell the whole picture. You could have patients who have low PSA and still have prostate cancer. You could have patients who have high PSAs and do not have prostate cancer. It's more the trend of the PSA that really matters, as well as combining that with digital rectal exam. So yes, PSA is still very important. Digital rectal exam is still very important. And the combination of the two is very important. And patients should see their primary care physicians and have that discussion.
Well, Dr. O'Goggin, since you have the floor, there's a question that I want to bring out right now, and that is, anywhere that I can get a PSA for free?
Typically, most insurance companies will allow at least one PSA screening a year.
This question is really about, I guess, a person that may not have insurance. What should they do?
There are a number of different programs. I know in Pittsburgh, we have different clinics. There are certain clinics, like the 9th Street Clinic. I think it's in around Waterfront. Patients can go there, and the physicians that run that clinic can order PSA for free. And a lot of patients can have certain tests obtained for free. Mercy also have run a free clinic. Mercy Hospital has a free clinic that patients can go to and be screened for PSA, and that I believe that is also for free.
Okay. Then I think it's important that we identify some of the free clinics. Birmingham, 9th Street is in Keysport. There are others, so that if you want to go to Alma Hillary or some of those other free clinics around the city, that might be a great opportunity to have that happen. Before we get back to cancer, there are a number of questions for Dr. Allen. One of them says, can Dr. Allen discuss the importance of blood pressure control? How should Black men get their blood pressure checked? At what age should the screening start?
Thank you for that question. As we all know, hypertension is a very ubiquitous disease process in the African-American population. We are prone to have hypertension. We are prone to have more kidney or renal vascular disease, and therefore renal failure. There we have a high incidence of African-Americans who are on dialysis and therefore are at higher risk for long-term poor outcomes. I think screening for hypertension should happen in your 30s. If you have a family history of high blood pressure, I would say in your 20s. And it's important to know exactly what your blood pressure is. I like to say you should know your numbers. You should understand that when you go to the doctor and the doctor tells you that your blood pressure is okay, that does not really mean anything. You should know your numbers so that you can understand that what your blood pressure should be. Recently, we look at a blood pressure of less than 130 as being normal. Anything over 130 to 140 is pre-hypertensive. So when somebody says it's okay, your next question should be, what are the numbers? And that relates not only to the hypertension, it also relates to what your cholesterol should be, also relates to how active you should be. So in answer to that question, yes, I think that you should start in the 30s or earlier if you have a very bad family history and you have other comorbid problems such as obesity and a positive family history of heart disease.
Just to finish with the heart disease questions, are there things that I can do to prevent heart disease in addition to knowing my numbers?
Yes, and these things are fairly straightforward. First, I think diet plays a very, very high role in preventing heart disease. A diet, there are many studies that have been done that shows that a diet that is low in salt, higher in fish and vegetables and fruits are related to better long-term outcomes. Now, I know that our population or minority population happen to be in areas that have significant food deserts, which is very critical for us. We have more fast foods in our area. We have more liquor stores in our area. We have less fresh vegetables, but diet is hugely important in relating to that, okay? Secondly, being more active. I like to say that you should walk more, at least 3 or 4 times a week. You should walk. If you're at work, don't take the elevators, use the stairs and keep active. And that activity will do a couple of things. One, it will help you with your heart rate response. 2, it will help you in your efforts to lose weight. And 3, it will also help in early detection. I usually tell my patients that if you're worried about heart disease, it manifests itself with physical activity. If you're active and you have no symptoms, the likelihood is that you do not have significant heart disease. If you're inactive, therefore you're not able to tell that for sure, and therefore activity is central to your well-being. So diet and activity is very important. We also have to be very careful, as I mentioned earlier, about your sodium intake, salt. We are plagued by very, very high sodium intake in the majority of the foods that we see and eat. I recommend that when you go to the food store, you should shop on the outside of the food store, the outer rim of the food store, because that's usually the area where you have your fruits and vegetables, where you have your frozen products. So that's where you should shop. When you start going into the middle of the food store, that's where the bad things happen.
Yeah, thank you for that tip, Dr. Allen. I guess I'll stay out of the middle from now on. I'll stay around the rim to make sure that I keep my sodium intake to a minimum. There are a couple of comments that I would like to make. There is another free clinic that has been called to our attention. It's called the Sheep Incorporated Healthcare in Penn Hills at 11817 Frankstown Road. So that may be another place where the PSA opportunity may present itself. So that's information that you can use. 11817 Frankstown Road, Sheep Incorporated Health Clinic. The other questions really, Dr. Evans, revolve around colon cancer again. I'm going to try to bring them all together and you can answer them, I think, as you need to. One is the discussion about the various screens. Can I do the Cologuard that they talk about on TV? Second is I recently had a second colonoscopy and was told it was clean and should not have the next one for 10 years. Should I assume the test indicated a digital exam of my urology, is it a digital urologic exam at the same time, or should I make that a separate appointment? So they had a colonoscopy and, will that stand for what Dr. O'Goggin said about the digital exam? And let's see, the final, at what age should I start my colon screening with my family? I had a family member who had cancer at 29 years old. So when should I start my cancer screening based upon family history of young cancer victims in the family? Is Cologuard something that I should use? And does a colonoscopy, now that it's free and it's 10 years that I will be getting another one, does that stand for the digital rectal exam that Dr. O'Goggin talked about?
Well, thank you for those questions. I'll unpack them individually. Screening. Screening, as we said, is the best tool that we have for early detection for all cancers. It is imperfect because, as you see in this patient, a 29-year-old, that person would not have been identified at an earlier time because there is no screening tool in place for that age group. For persons with family members or parents who are diagnosed with cancer, it is recommended that you start screening if younger than 10 years younger than the age of the principal person who was diagnosed with cancer. So of course, for the 29-year-old, it would be very important to know what their genetic studies reveal from the tumor assays. Next, what are those screening tools, and what specifically is the Cologuard test? There are tests that look and evaluate DNA and blood within the stools, which is considered non-invasive. You collect your stool sample and mail it into these diagnostic facilities, and your results return. The Cologuard test, believe it or not, is 92% accurate. Nothing, of course, beats colonoscopy, which means the actual evaluation of your entire colon with a lighted camera and scope. With that tool, colonoscopy, you can actually sample any abnormal growths called polyps within the lining of the colon. After that, another option is, if you're not evaluating the entire colon, we can also evaluate just a portion of the lower portion of the colon, through a scope again, and that's called flexible sigmoidoscopy. And another new intervention, non-invasive as well, is called CT colonography, where a CT scan is performed in a special fashion that can look at the lining of the intestines. But if those tests identify an abnormality, you still end up requiring a colonoscopy so that the tissue can be sampled. Cologuard can identify early growths called polyps, which can be precancerous tumors. And the recommendations for CT colon for those tests are the stool DNA fit test is 1 to 3 years. CT colonography is once every 5 years. Flexible sigmoidoscopy the same, and colonoscopy is 10 years. So I hope that was helpful. And know, when you're having your colonoscopy, the emphasis is not to evaluate the prostate. So that is a separate evaluation that should be performed by your urologist. Thank you.
You want to comment, Dr. O'Gauguin, on separating those exams and setting up different appointments for those procedures?
Yes, thank you, Dr. Pettigrew and Dr. Evans. As Dr. Evans says, yes, the colonoscopy does not replace the need for a digital rectal exam. The digital rectal exam is something that the finger typically will feel. And what are we feeling for? We are feeling for what the prostate feels like. Does it feel hard? Does it feel smooth? Is it, very enlarged? But really, the hardness and the lumpy and the bumpiness of the prostate is what we feel for, and that gives us an idea: is this patient someone that we should proceed with a biopsy? The digital rectal exam doesn't tell us that you have prostate cancer. It gives us an idea that you may have prostate cancer. It is not a perfect, exam, because there are some prostate cancers that are deep within the prostate or maybe small that we will not feel when we do a digital rectal exam. And that's where PSA comes in. Especially, like I said, if you have a family history and if the PSA is gradually rising, then we use that opportunity to do a prostate biopsy. There's another tool that we have that we've been using more lately, and that is prostate MRI. So for patients who do not want to have a biopsy, and if they're having a rising PSA, an option will be to do an MRI. The MRI will give us a better idea whether or not we should be focusing on, a specific area of the prostate that could be harboring cancer. We will still need to do a directed biopsy to that specific area, but it will be more limited, more controlled, more direct biopsy to a specific spot that looks concerning on the MRI.
I hate to put you on the spot, Dr. O'Goggin, but when you use the term digital, that may make people think it's electronic. Let them know that that's when you put the glove on your hand and whatever it is you're feeling for, you do it that way.
That is correct. That is correct. We have 5 digits, and this digit is what I'm referring to. Right.
Okay. I just wanted to make sure that they knew that wasn't a little electronic scope that was going somewhere. I can tell you, Dr. O'Goggin can make it not hurt so badly when it is happening.
Thanks.
It is an important test.
Yeah, it is an important
test to take.
Thanks for clarifying.
Yeah, thanks. Before we leave cancer, I'd like to just ask a question about diet, Dr. Evans. Dr. Allen talked a bit about diet, and are there any things rather that we can do that helps us to minimize our cancer risk through diet? That's the question. The question also brings pesticides into the conversation. Are those issues that can impact our vulnerability?
Thank you again for those questions. When you talk about what are the modifiable risk factors that affect outcomes in all cancers, and as we stated this evening, smoking and cigarette smoking is number one. And when it comes to diet, and we talk about colorectal cancer, we do know that if high fiber diets can be effective tools in mitigating colorectal cancer, causing evacuation and shedding of cells as they turn over in our intestines. So 25 grams of fiber is recommended in women and 35 grams in men. So we really have to, as Dr. Allen said, stay in the periphery of the store where the vegetables are. So green leafy vegetables has the highest antioxidants. We also know that vitamin D is an important vitamin for cancer prevention. So we have to look and do those products, milk and all of those other agents that might contain higher doses of vitamin D to help with our immune system. And I'll leave it at that for this moment.
All right, thank you, Dr. Evans. We want to now move back to Dr. Allen so he can tell us whether diabetes has an impact on heart disease.
Oh my. Yeah, diabetes, I like to call the great equalizer. So it's one of the most important risk factors for vascular disease that you have. And you'll find it presenting in our patients and individuals that are not the classic smokers, high cholesterol presentation. That's why I call it a great equalizer. That being said, it means that it is so very important with regards to diabetes that you get your diabetes under control. And to know, another number to know, if you're diabetic, what is your hemoglobin A1C? that is really a predictor of what your glucose has been for the preceding 3 months. And it helps determine control. So the people who present with diabetes, they have such bad vascular disease, and the vessels are so significantly impacted. They're much smaller, they're more diffuse in its presentation of the disease process, and thus makes it much harder to treat. So I plead with my diabetics to get your diabetes under control, because it's so very important into your long-term outcomes.
Thank you, Dr. Allen. There is a comment for you that says, thanks for letting us know that we should stay out of the middle of the grocery store. That keeps us away from cans, boxes, and bags. So
That's correct.
Dr. Evans, you mentioned screening for lung cancer via low-dose CT scans. Can you say more about that, particularly as it relates to those who are not smokers?
Well, unfortunately, when it comes with regard to smoking, even if you're around someone in the same room as a smoker, you are considered a smoker and are impacted by that exposure. So age 50 to 80, smoking 1 pack of cigarettes a day for 20 years, even if you've quit within the last 15 years, a low-dose CT scan can identify 80% of lung cancers at the earliest stage and also improve outcomes. Unfortunately, 34 million people still smoke in the United States. So this is where opportunity exists, and we yet do not know the full impact of the use of e-cigarettes on all of the public health.
Okay. I think we have addressed all but one question. And that one, I'll give all of you the opportunity to deal with. We're coming to the end of our hour. So I know you could all talk about this for a long time, but I'll try to keep us on time. And the question is, what advice do you have for young Black men in college who are interested in pursuing medicine? Now, I know you can't answer that question in less than 5 or 10 minutes, but let's see if you can make that happen. We'll start with Dr. Allen. We'll start with the A's and we'll go to the E and then we'll go to the O.
Okay, being interested in medicine, I think that first thing you have to do is get into some stimulation programs, STEM programs. Sciences are hugely important in getting into medical school. And we talk about, you know, the problems with our test taking skills, but science is hugely important. And I think that having that sort of support to understand this will put us up over the hump. It's hugely important for you to seek help in getting to that stage. Now, that and going on and see if you can volunteer somewhere. If you're in Pittsburgh, at the University of Pittsburgh, and get aligned with the program, that would be very good. Gateway Medical Society also has a program for young African-American men and boys called the Journey to Medicine program, which you should avail yourself of if possible.
Dr. Evans,
Well, I just want to put a
advice from
plug.
you.
I just want to put a plug in as director of community engagement. One of my tasks is to help build a pipeline of underrepresented minority in medicine. And believe it or not, you're at this very meeting, you are privileged to see physicians of color. Nationally, Black male physicians represent less than 3% of our nation's physicians and doctors. So representation matters. The only way that we are going to help eliminate disparities in cancer outcomes and health outcomes amongst people of color, Black and brown communities is through increased representation, improved messaging. So mentoring is important. So find someone to email someone that you may have observed through a program, tell them that you're interested in medicine. Can they take a moment with you and respond to your questions and your concerns? And that's the start of conversation, start a relationship, become a mentee, and become aggressive in your pursuit of excellence. And you will become, in reality, the vision of what you realize. You will become the physician you dream to be.
Dr. O'Goggin.
I will have to echo those sentiments. I think that having a mentor that you look up to makes you want to emulate what your mentor is doing, and that by itself will make you work hard and try to do the best that you can. But having a mentor that you look up to, there's nothing more important than that. And I know that when I was in an undergrad, having a mentor of color really mattered. Having a professor of color really mattered. And not only did I feel like I don't want to let them down, that made me, try to work harder. Because, if you are one of the few, African-American student in the class, that makes you want to work harder, knowing that professor of color will be paying close attention to what you're doing. So seeking out a mentor is very, very important, and just work hard, work hard, work hard. It's a dream that is not impossible.
Okay, that is great advice. As one who watches this happen time and time and time again, I would say work hard, seek excellence, get great grades, find a mentor, figure out what you're going to do in terms of your test preparation and development. Do research, whether it's in the summer or during the academic year. Make sure that that is happening. Make sure you apply when you're the best applicant that you can be. Don't apply just because you pick an arbitrary date. Do all the things that you need to do, line them all up, and then make sure you're the best applicant that you can be, and then know why you want to do this. I think it's very important that you're able to articulate that. So if those things happen, then as everyone has said, the opportunity can present itself and you can take advantage of it. But there are two other questions that have come up, and I don't want to leave anybody hanging. So we're going to take these two final questions. Anybody can answer it. Cigar smoking has become so popular among Black people. Is cigar smoking safer than cigarettes or weed? Verbatim. Recently, I started feeling back pain and leg pain. The doctors did an ultrasound of my heart, lungs, and legs for possible blood clots. And I was told everything was clear, but the back pain is on and off. What should I do? Those are the two last questions. And when these questions are answered, I'll close this out.
I think that smoking is smoking. As long as you're inhaling the tobacco, I think that is a risk for having lung disease. As Dr. Evans said earlier, even if you are not smoking yourself and you're in the room where someone smokes a lot, like your partner or your friend, it's tantamount to you also smoking, because you're inhaling the products and you're going to get some of the effects as well. So I think that cigar smoking, cigarette smoking, and at some point we'll find out more about the other types of inhalants. We'll hear that later, but for now, in my estimation, all smoking is smoking. And interestingly, if you look at the two leading causes of death, heart disease and cancer, what is a theme that runs through both of them? Smoking.
And anything about the ultrasound question? Anybody want to address that?
I think that's a little bit hard, because you have to not only look at the ultrasound, you have to look at the thing about diagnoses is a diagnosis is not a test. A diagnosis is a combination of seeing the physician, who then orders the test to confirm what he's thinking. So just presenting a test by itself, you cannot make a diagnosis in that regard, because that could be anything. So I think that it's a very loose question, a good question, but not very specific that you can really, I'm sure none of us have a specific answer to that, because it could mean any of a number of things. It's a combination of things that put in together a diagnosis. And the first part is speaking to the physician, answering the questions that he asks, and that will lead him into what needs to be done. Because most importantly, the patient will always tell you what's wrong with you before you finish. Before you put your hand on them, you know what's wrong. So that's most important.
Right.
Let me just say one thing about smoking. I didn't say anything about bladder cancer today, but smoking is one of the highest risk factors for patients developing bladder cancer. So we didn't talk about bladder cancer today, but that is also another disease that, can affect the African-American population and patients who are heavy smokers. So smoking, leading risk factor for bladder cancer.
Okay, gentlemen, it would lead me to say, based upon the things that I know, is that if the pain is still there, you don't have a diagnosis, even though you've had an ultrasound. So it looks like you're still in pursuit of finding a reason for that pain. So you need to continue to do that. I want to thank our panelists. These are some esteemed gentlemen that I've had the pleasure of knowing, working with over the course of time. You've had an opportunity to hear from them. It's been an exciting evening, so thank you for all of your comments, Dr. Allen, Dr. Evans, Dr. O'Goggin. I finally want to thank our sponsors for this event, for providing the opportunity for us to communicate with community members in the city of Pittsburgh and Allegheny County. Those sponsors include Highmark, UPMC, Gateway, Heinz, the Heinz Endowment, the Links Incorporated, and the Black Nurses Association, along with Chi Eta Phi, and the Allegheny County Health Department. We want to thank all of those sponsors for making this evening and event possible. Thank all of you for signing on, and hopefully you will heed all of the things that have been said to you. You will take better care of yourselves, because it is us that have to keep these families together. And the better care we take of ourselves, it means that we'll be able to do our job at 100%. Thank you all again, and good evening.
Thank you.